All right, welcome back. Hopefully those were exciting and interactive sessions. We are now going to call our moderators, if you don't mind spotlighting all of us, and we are going to kind of reflect on what took place and report out. So we're going to go in order, but you can go ahead and let's get all our moderators on. And what we'll do for our report out is we'll show the case for your room. We have that pulled up on the slides. We'll give you a chance to kind of describe that, and then kind of share what the highlights were in your room, what interesting discussion points were made. If you received any solutions or interesting approaches to kind of meet your scenario, and generally if there was anything. I see a lot of smiles, a lot of faces, maybe even just some first impressions. This was our first time really trying to do something like this. And so there might be just some of that, right? That was odd, that was strange, that was great, that was wonderful. So feel free to share some of that as well. I know we're still gathering some of the other moderators, but we are going to be spotlighting first. We'll start with our birth and maternal health room. So Brandon, if you would spotlight Sue Cresley and Laverne Purley. We'll wait for those individuals to come and get, yep, Sue and Laverne. Let's start with you both. Let's pull up your room scenario for birth and maternal. Tell us a bit about the scenario. Tell us a bit about what happened in your room. How did it go? Go ahead and get started while we get those slides pulled up.
Sure. So we solved all of the problems, Tricia. You'll be happy to know. No, it was a really great discussion. Our use cases are: we have an infant who clearly can't consent on their own, capturing a mother's consent, one to share immunization information with another HIPAA-covered entity, one of the specialists, to share information with a non-HIPAA-covered entity to a court, for example, if there's a custody battle related to, they wanted to know the mom's substance use disorder and testing, and then to the parent themselves if they want to maintain information their own. And this might also, most people don't know, most infant charts have commingled maternal data that can't be currently segmented and taken out. So the baby's data would have, for example, the mother's perhaps substance use history in their data, which is important for care. And so let me just start by saying, when we talked about digital consent solutions and eConsent solutions, the majority of our participants are still collecting consent on paper. There was a discussion about the requesting consenter, if you're going to share across state lines, et cetera, and fax me a consent, signed consent. There was a discussion about digital solutions. Most of them came from the originating technology. There was nobody who had a patient solution saying, I want to use my consent solution and share it with you, healthcare entity. That did not exist among any of our users. There were a lot of people who had quasi-digitized consent solutions, which is, a capture data screen upon check-in, but it still shows up in a not necessarily e-technical way inside the consent solution. And a lot of it is because the workflow of having the need to capture consent in multiple ways, whether the patient's in front of you as at a check-in kiosk versus having a piece of paper they sign in consent and can be uploaded, or as part of an onboarding new patient packet, giving consent. We also had a very interesting conversation about the ability to explain to patients what they're consenting to, and nobody felt comfortable that they felt like we had a good solution in meeting patients where they are, so they know what they're actually consenting to and sharing. There was a discussion about, should we learn from other entities like consumer consumer marketing firms, which really test and retest messaging about what, so they get it right, to people understand it, but also that in our world, we can't expect, if we're going to address health equity, that it's one message that'll work forever. We have to figure out how we have repeated messaging that targets specific populations so that they know what they're actually consenting to. We also talked about learning from other countries that are already sharing data better than we are, but that's a societal probably conversation that needs to be had. There were standards being used for consent, included everything from FHIR to IHE's BPPC and APPC and NIEM, all over the place. And then there was a consent conversation about whether should we be mandating one standard and moving to one standard like FHIR, or should we be living in the real world where people have different technology standard solutions and figuring out how to build a way that's encompassing of all of them. We also had a very interesting conversation about the lack of robust research into how patients really want to share their data, and where is the conversation on that balancing act between sharing data and privacy. And even if we had a conversation about the people who do share electronic consent to their next, when they're sending data, they've got captured consent in a standard and they share it with the next entity, it's imposing often the rules of the people who captured the consent. Should we be forcing the rules of consent of the consenting originating body and then sending that to another healthcare organization and imposing those rules on the second entity? Maybe they have their own set of rules that don't necessarily jive with the originators, which was really interesting. We talked about, utopia of public sharing data. Where do we share? What should be shared? What's the common good versus the personal good? And that's not a technology solution, and we all know that, but it sounds like there's a lot of opportunity. Nobody's really solved this, and there was a clear need to figure out how to do this in a more granular, segmented way, because even depending on what you're sharing and who you're sharing it with, we have to make it so that, it's not too hard to maintain on the patient or the clinician team's work, but we have to get to the point where people have better trust in what they're sharing. And we have to also learn as a society what people are willing to share and for what reasons. Laverne, what did I miss?
I think you have it all covered. It was a lot to cover. It was a lot of discussion.
Yep. And we have a disclosure to make. We may have not been able to save the chat. So anyone who put in great resources during our work group, share them here with a broader audience so that we can all learn from each other. That would be very helpful, because not everybody will be able to necessarily get the chat that was in all our breakout sessions. So thanks. We had a great group of people and we really appreciate the engagement.
Wonderful, thank you. Let's move on to our next breakout room, the childhood room. So Christine and Angelina, you're next.
All right, thank you, Trisha Lee. So we had a discussion that I think went in a few directions I wasn't necessarily expecting it to, so that's good, I guess. So I'm going to give you just a few highlights. In terms of technology, the technologies that were referenced repeatedly were essentially existing technologies, and largely came down to portals and the ability, at least in theory, and some portals either of electronic health records or of NHIE for the person, in this case, the mom, Mrs. Dexter, to be able to go into the portal and give access to somebody who's outside of that system, or to sort of log her consent for the glass to be broken, or whatever, terminology you want to use, for multiple providers that are sort of within that same system. So that would really cover the first scenario here, where the child's pediatrician or primary care physician is likes to see the evaluation and the plan of care from the psychiatrist. So that was really what was mentioned. And similarly, for the final example for Mrs. Dexter herself, that she often would have the ability to go in and get those records herself from a portal. There really weren't any other sort of electronic solutions that were mentioned. Now, interestingly, that discussion about Mrs. Dexter getting these records led to a discussion that I didn't expect in the childhood group, although I thought maybe we'll hear soon about it from the adolescent group, but that even though Stu is only 10, it may be possible under certain state laws that these records are confidential services. And so that was one of the things that got brought up. And then secondarily, that, and I just lost my train of thought there. That's terrible. That they could be confidential. Oh, and that the parent might not be the custodial parent. And so there was a discussion about how important that it is to actually use electronic systems that have verification of the user, so that we're making sure that consent, particularly in the case of proxies or even people, holding themselves out to be themselves, really are who they are. So I thought that was an interesting point that was made, that we're going to get potentially more accuracy in consents by using an electronic system. And then when we got to talking about the schools, what was interesting to learn was that right now schools have a lot of siloed data systems. They actually might have 3 different data systems in which health information is being stored. So one of the questions was, even on their side, if a consent was sort of collected and sent to Dr. Fonda, where would it live at the school? It's not even clear where, in what electronic system that would live at the school. And then I did hear from one of our speakers who got cut off, but she was able to fill me in via email, that there are health systems that are giving school providers read-only access to their electronic health systems. So again, exactly how that consent piece was captured, I don't quite know yet. But in terms of how that information exchange could occur once that consent is there, that would be a possibility. Anything that I missed, Angelina?
No, I would just like to say that we all, aside from people in the healthcare profession, we had contributors from the technology side and also just as parents. So I think that really added to the conversation, because we had people making comments as parents of teenagers and also as app developers, not just those that are professionals in the medical and health fields. Trisha, you're muted.
Thank you. Thank you. Let's go to our next room, the adolescent room. So Hannah and Liz.
Yeah, thanks. And we had quite robust discussion as well. And thanks to everyone who participated. And thanks to Liz for all her facilitation and taking great notes as well. These were our use cases. We were dealing with a 17-year-old Alyssa who first was seeing a specialist. So within a HIPAA-covered data exchange within HIPAA-covered entities and consent for sharing data, and then needed to share data with an employer at a summer camp, and then through a health app and requesting data from the PCP, or the health app submitted a data request to the PCP for test results. And we considered both non-sensitive and sensitive data in all of these scenarios. And so regarding the first scenario, we had a good conversation about whether consent was even required, and would it only have to be captured in states that require opt-in for treatment purposes, and how you would identify that the other specialist was treating the patient, and so what's usually used today, and that, again, like others have mentioned, that even in these scenarios, today, a lot of this consent is on paper. It may go through the health information management departments, and consents are submitted often through paper or through fax, that we don't have a lot of good standards for metadata to travel with the data from the source data, that with adolescents, there need to be nuances around the parent's role in regard to the adolescent, and there needs to be some co-governance around who's consenting to the data, who is assenting, and how they interact. There was also a lot of good discussion around second opinion issues and where there may be a need to get independent data for a second opinion. And so do we want to give full disclosure of the data to the specialist who's giving a second opinion, potentially in this case, and how a patient or a patient parent in this case might specify, you know, I don't think that the specialist should have all the data because we want an independent opinion here, and who might, you know, make that determination. And that a lot of the ways that may be happening in current state is that the patient is getting their own data and then deciding what data to pass off to the specialist, as opposed to it going from one HIPAA covered entity to the other directly. So that was a good discussion there. And Liz, please feel free to speak up if I missed anything on that. There was actually, I think, some introduction to the discussion around the ability to segment the data, especially around behavioral health or other sensitive data that might be transmitted, which we got to a little bit more in the employer scenario case, where this is a core sort of challenge for pediatricians, not just around employers, but just camp forms and school forms. And we discussed how in current state, this is often very vendor specific functionality and done very manually by providers to redact data that maybe shouldn't be shared. And again, some co-decision making and co-governance potentially with the adolescent there or with the parent, similarly with younger children as well. But it's really done very manually in current state. And we talked about how it's sort of sidestepping consent with manual paperwork, because we often hand that paperwork to the parent or to the adolescent, and then they provide that to the employer. And so there's not really a consent process there, because you're actually giving it to the patient, and that's sort of presumed or assumed consent in those situations. And so we also talked a lot about how large vendors may be moving forward with some granular segmenting functionality for these purposes, in sharing with the patient over the portal or sharing with the parent over the portal. But there's not a lot of interoperability there if each vendor kind of develops their own functionality to enable this. So you know, we would like to see that for interoperability purposes, to have some national, some standardization around that. The big takeaway from this discussion was that tagging and data segmentation should be included in regulations going forward to advance interoperability and privacy. We also talked about looking toward the future, and should there be some type of centralized eConsent management going forward. So if a consent has been enacted, should that live in a registry somewhere so that that can be referred to or redacted going forward in the future. So there was a good discussion around that, and would there be issues if that tool or that registry was regional? What would be the processes around that, around those? And then scenario number 3 with the app, we talked about, and so some folks are really doing this well currently. There's a Be Well connected health application or platform that can be white labeled by a health system that allows for some rules where a health system can say, you know, patients after a certain age can be given the authority to create an account and request data from their EHR with a tethered app functionality. And we talked about that a little bit. Change Healthcare does have an app as well that has some ability to segment data according to state laws, or allowing organizations to specify those preferences. But you know, we talked about whether or not you know, where those policies should allow, at what age, right? Is it an age specific? Is it maturity specific? policies to allow whether the patient should be able to request their own data, and at what point does the parent need to be involved in that consent process as well. And so we had a pretty robust discussion about that, and it makes it really difficult, as I think we all know, that all of these rules and regulations vary state to state, and so some harmonization there, or the ability to understand and have an IT tool to be able to drive the different the different regulations by state and laws by state for these purposes would be very helpful. So I think that's kind of where we ended. Liz or anyone else with anything to add?
Yeah, the only thing I would add is that there really seemed to be a common thread across all three scenarios around the need for data segmentation and data tagging, and also an ask for more, not really oversight, but regulation requirements for certification around data segmentation, because large vendors may be more progressive about doing this sort of work already, but in order to get that across the board for interoperability, there's if it's not required, then it doesn't happen. So that was kind of one of our common threads across the board.
Yep.
Awesome, thanks. So the adult room, Stefan and myself moderated that room. You can go ahead and display that next slide. Our scenario, we had the Pam Levington, and she is receiving care from one provider who is moving to a new facility. She would like to have that continued care with this provider at the new facility, but wants to restrict access at the new facility because she knows someone who's employed there and does not want that person to access her records. Pam is also wanting to enroll in a research clinical trial, but there's an online enrollment process that would need to look through her medical records for eligibility, et cetera, and she wants to have her provider share only the necessary information needed for that clinical trial enrollment. And our third scenario was to have a copy of her medical records so that she can take that to a provider of her own choosing. She is not, still has reservations about the new facility, XYZ, and wants to be able to take her record and find a provider that she wants to get care from. Overall, we had great dialogue and discussion in our group, thinking about what is needed from a standards perspective. There were, I guess, three things that main points that I captured, and Stefan will help fill in some of the gaps. Some of the prerequisites that we discussed in our room to enable these scenarios would being able to segment the information in her record such that she can specify what information she needs to be restricted or shared. We talked about the need for good access control models that would be helpful in that first scenario where she would like to receive care at a facility but does not want her sister or any other, I guess, unauthorized provider or individual to see certain information. And we also talked about the need for being able to have good provenance and data or some type of way to understand where data is coming from. In that third scenario, some points were made that there might be hesitancy from organizations or providers to accept a medical record from a patient. They don't understand if there's questions about whether it was altered or not. I'll tell you the highlight for me in that portion of the discussion where I learned something new. What was shared was that there are instances where in the incarcerated population, that county jails will often give their records to individuals who are leaving those facilities, and they then take it to providers. And it was just fascinating to me to think that there are scenarios where there's more trust in those situations, and we're still kind of working on how to do this ourselves. So that was kind of a fascinating point that was raised. we talked about kind of where are good models to see this done, or where could we look for good examples. We had an example from a payer who shared that they do this routinely, that they're able to allow beneficiaries to determine which information they want shared with which individuals. However, that there are limitations in how that can flow out to other organizations. We had examples that we can look to the consent to share work, and that also W3C has decentralized verifiable identity work that's taking place that could be helpful in verifying who's doing what, and that a record could be accepted at a new facility. So that was kind of interesting. Another point that was raised about kind of in this scenario was, we're talking again, the premise here is that the information is in the hands of a healthcare provider. But the point was made that, when do we get to a point where we kind of flip it, where it's actually individual who's managing and the individual is really directing their information. So it's less of a consent, but just saying, here you go, the kind of handoff. And so that point was made. We had a really active parking lot, and I'll just give you a couple highlights from that. In our parking lot, we had at one point, and again, there's a lot here, but I'm just going to read something here. One is about kind of who stores the consent, who owns the consent, who manages the consent, where does the consent really live? Is the consent at the organization A, or is it at organization B? And so that was an interesting point in our parking lot. And there was another point in here, oh boy, I'm not seeing it, or at least I lost my my point. But in any case, we had a huge parking lot to go through with lots of interesting things to kind of work our way through. But again, thank you to everyone who participated in our group. And Stefan, did I miss anything?
I'll be real quick because I want to make sure we reserve some time for our last report out. A couple other things mentioned was there's an interesting linkage with the work under the International Patient Summary, the ability to wrap data on a bundle. And so that was kind of brought up something I hadn't thought of in the context of this. It was highlighted several times about not only the need for data segmentation, but also the re-identification challenge when using the data for things like determining clinical trial qualifications and whatnot. And then also Jan had Oldenburg had a great point on that the resource that governs provenance isn't very detailed and could be improved to ensure trust. I hope they got that right. But there was something else, I'd love to have a follow-up conversation on as ways to improve that and get more detailed in it. And then lastly, just to mention the direct trust efforts. I was aware of this, but would love to dig a little deeper into it. And I guess direct trust has a federated model for consent release of info, managing consent for release of info. So those were kind of the key elements there. And I think we should probably quickly move on to onto our last presentation, because I know we're running out of time. Maybe we'll go a few minutes late to give them appropriate amount of time.
Try to keep us on schedule, Stephen. Thank you. So breakout room, we presented 3 cases of Mr. Bill Howard, who really is just becoming progressively more ill in his serious illness journey. He completes some advanced care planning wishes with his cancer center, and then becomes more debilitated and has to live at a skilled nursing facility, and they want to exchange information. He then develops an acute illness, becomes unresponsive, and has to call emergency medical services. And how do they access information? And how is that information then transmitted to the hospital? And lastly, at the hospital, unfortunately, Mr. Howard is now incapacitated. His durable power of attorney comes and wishes to reconcile some information that seems to be incongruent with what he has now versus what's been completed before. This kind of framed our conversation. We didn't map to this specifically, but in the course of our discussion, we really kind of hammered in on this notion that the goal really is here to how do you make a person's care wishes known? There is definitely the consent element as they move across sites of care as they get more sick, but also a data capture and recapture component too, especially given how information changes over time with the experience of illness. We identified current state as being very suboptimal. The consent process is largely hospital and facility driven, very low tech, usually wet signatures on blanket forms that are neither discrete with what's being released nor intentional with how that data will be used. That data is sometimes pushed through a CDA format. Sometimes it's actually just scanned as forms themselves. And even for our point of care responders, our first responders and EMS, they have their own EHR that doesn't link necessarily with hospital-based EHRs, the NEMSIS system. And so there's opportunities for information flow and consent to be more optimized, but still very underdeveloped. thinking about where we could go from here, there was a real wish and momentum towards interoperably sharing more discrete data. HL7 is working on has a consent resource, building a FHIR standard that'll work with APIs, and that is open access. So it's not limited just to kind of a clinician echo chamber or technologist echo chamber. There's a lot of patient perspective and voice as well. There's identified a need for common language, not only in how consent and information flows, but also the common language on how do you capture the very unique information relative to the care for patients near the end of life, some of which is very close-ended, for instance, resuscitate or not, and other which is very open-ended. What is important to me as I become more ill? What would I not tolerate as my illness progresses? And there's complexities for that that vary across document type and states as well. Lastly, we talked about how do you distribute information. Our statistic was shared that 80% of patients are incapacitated near the end of life. So this consent and decision-making really is very asynchronous and temporally dislocated from the actual point of care. All the more need for this process to be very preemptive and to be very clear. One solution that was presented is essentially a patient-empowered centralized repository that goes over all the consent processes, codifies the information, and then delivers it to various care delivery stakeholders as the illness journey continues. Lastly, we forayed into this sense of how the majority of Americans wish to age in place and to be treated in place. And so in this journey to more care for people where they are, there's going to be a lot more non-traditional entrance into the connected care ecosystem, not just hospital and brick and mortar based care, but various home-based and virtual first and others wraparound services. How do we engage them? What is the consent process going to be? What information do they need to access? And also for non-care delivery, organizations that also contribute to the care experience, like meal delivery and other support services. What is it that they need to know to be involved in the care effectively? And what is the process by which they obtain part of that information and not? So overall, I would say we had a lot of thoughts about where we go from here and how these things can come together.